Hello, welcome everybody to The Ordinary Doctor. I am the Ordinary Doctor, Dr. Manan Mehta, with the extraordinary Dr. Aditi. She is a gynecologist and an obstetrician, and she's here with us to speak about PCOD. Hi, welcome Aditi. How are you?
Hi. Thank you for your kind introduction. I'm good. I'm very happy that we've chosen PCOD today because that is something which is so common and which is something that you and I are dealing with every day, that it needs to be addressed and we need to simplify it for people so that we can deal with it at a ground root level and not make a big deal out of it and, tell people that this can be tackled easily as well.
Do you feel that the incidence of PCOD is on the rise? ज़्यादा लोगों को PCOD हो रहा है ऐसा आपको लग रहा है?
Absolutely. In fact, the other day I had a talk with my boss, and she just told me this that like 15 years back, when they were practicing, they would hardly see PCOD one or two cases in a month. Now they see two, three cases in a day.
We use these terms interchangeably sometimes, especially our audience, that PCOD and PCOS, are they the same thing? Are they two different things? What are we dealing with?
Honestly, they are the same. Now, when we are talking about PCOD or PCOS, what happens is, and this is where the patient gets a very false sense of security कि मेरे ovary के sonography में अब तो cyst नहीं है. So that means I'm cured of my disease. But PCOD by definition includes a lot of parameters. When we are talking about PCOD or PCOS, you don't only have to look at the cyst in your ovary, you also have to see your hormonal balance. You also have to see whether your cycles are actually coming on time or not, and whether or not you are actually ovulating. And then there are signs of hyperandrogenism, which is your typical hair loss and hirsutism and pigmentation of the skin and things like that. So all of these things or a few of these parameters actually constitute something known as PCOS. And even while treating the patient, we are not only looking to treat the sonography report, we are also looking to treat the entire patient in toto. So we have to take into account all of these or whichever factors that the patient is suffering from.
Basically, you're saying that most of the diagnosis of PCOD, PCOS will be clinical and not just on the basis
Correct.
of
Correct.
ovaries में cyst
Absolutely.
दिख रहा है या नहीं. Right. Also, you said a few symptoms. Could you explain them a little better? On the hormonal side, irregular periods, and hirsutism means hair growth around the lip, chin, etc.
Right.
So, what is
Right.
normal? What is abnormal in that?
Yeah. So let's start with our menstrual cycle. Now, normally your menstrual cycle, now it varies from female to female, but ideally you should get your periods every once in a month, whether it could be once every 21 days or maximum going up to once every 35 days. Your 21 to 35 is your normal parameter. If you start getting periods earlier than that or later than that, both of these are considered abnormal. Coming to PCOD, usually it tends to delay your cycle. So these patients typically will not get their periods for, let's say, 40-45 days. And if the disease goes undetected for a while, then these patients also sometimes do not get periods for 2-3 months at a stretch as well, even longer sometimes. So these are usually and again, the flow reduces. So earlier, if the patient is bleeding for, let's say, 4 or 5 days, her cycle will reduce to only 2 or 3 days of lesser flow. So the consumption of pad or tampons will reduce, the days will reduce, oligomenorrhea, which is what we call it. It is likely to happen in such patients. Now, the second parameter is hyperandrogenism. Now, hyperandrogenism would include things like loss of hair, like a male pattern balding. Don't don't check your own hair, but male pattern balding, typically from the forehead and from the top of the head. You start getting hair where you don't want it, which is your chin and upper lip. And there is darkening of the skin of the nape of the neck. So this hyperpigmentation that we usually see here. Along with this, there is belly fat. There is increased weight of the patient. The patient complains usually that I'm not able to lose my weight as much. The other problem, if we could talk about it, is fertility related issues. These patients, because of the hormonal imbalance that they do not have a regular ovulation, which should happen in the middle of the cycle.
You said the darkening of the skin. Acanthosis nigricans is something I see very often. And when we see that, we immediately say that, listen, I think this is insulin resistance jo ho raha hai aap mein. So fat is creating a lot of these problems, and a lot of these problems are being created by fat. What would you say how do you manage a garden variety case of PCOD? What is the advice you would give in terms of lifestyle modification?
So the first advice to all my patients is lifestyle modification. Uh, Now there are two types of PCOD that we come across. One is a lean PCOD, the other one is a fat PCOD. Lean PCOD, we'll put a pin on that for now because that is not as commonly seen. Let's talk about your typical PCOD patient who's slightly overweight and as we described earlier. So this patient now, because what you correctly said, insulin resistance is the problem. So you could say this that this is two steps behind diabetes. So whatever diet you would actually recommend for a person who has diabetes, where the problem again is insulin resistance, this PCOD person also needs to largely follow the same kind of diet. So we always tell them that carb is your enemy, protein is your friend, because their protein metabolism is fine. It is the carb metabolism which has taken a hit. So usually rice, ghee, butter, sweets, maida. These five things are not something that are good for you. You will not be able to digest it. It is not a matter of consuming only two chapatis or only one bowl of rice. Your body cannot process even that much. You have to accept it. On the other hand, to compensate for that, you have to start finding more sources of protein in your diet, which could, regardless of your vegetarian or a non-vegetarian status, you could find protein in your diet, including dal, pulses, chicken, fish, eggs, whichever way anybody wants to have it. That is one of the biggest factor that helps the patient. And when you want to lose weight, I'm sure, as we all know, it is 80% diet and only 20% exercise. So diet plays a very, very big role in that. And you need to put the patient on a very strict diet for this. You cannot rely only on drugs for treating with this, because that's just artificially creating a cycle for the patient. So that gives you a false sense of security. Once you put them on a pill, they feel कि मेरा महीना तो अब regularly आ ही रहा है, so now I'm back on track. But that's an artificial cycle that the doctor has created for you. Your internal cycle is still bad. And that will only be corrected once you actually start rectifying the internal problem of insulin resistance.
Yeah. It's not
Correct,
just
correct.
ovulation and you
And
get periods and problem is solved.
yes, absolutely. Yeah, what you're saying is absolutely right. So we have to first deal with the core problem of insulin resistance, where the diet plays a very, very important role. Exercise, now, as much as I want to tell my patients that exercise for 40 minutes a day, every day, that doesn't happen. So what of late, what we've found is that we tell them to do, even if it is 10 minutes, 4 days a week, try to include high intensity bouts in between. Don't walk. Walking is not exercise for a young girl of 20. That is not exercise for her.
I would say
So
walking
try
is the
to do.
purpose of evolution. You've evolved so that you can walk. Don't classify it as exercise if you're a young lady.
So you have to either jog or swim, Zumba, dance, aerobics, whatever works for you. But anything which increases your heart rate and makes you sweat.
Can a woman, diagnosed with PCOD lead a normal life?
Absolutely, absolutely. Okay, on a personal note, I have PCOD for the last 14 years. So it's not something that will hamper your life or lifestyle. It's just a matter of being a little disciplined with yourself. You have to accept it that these are my limitations. I cannot eat certain things, as like you all have cheat days, but you cannot indulge yourself very frequently. And once you've achieved that weight loss, you have to maintain that.
Agreed. But see, diagnosis is tricky. A lot of patients say that, okay, you have cysts in your ovaries, but you don't have PCOD. Some patients have PCOD. Where would you say, how do you diagnose a case of PCOD? Do we rely on sonography alone? Or in what conditions would you want us to get a hormone profile done?
Largely depends on what patient is complaining of. So
Okay.
if there is, I will give you three different scenarios. So if there is a 16-year-old or 18-year-old girl who is complaining of her cycles getting delayed and not getting her periods for, let's say, 3-4 months, for her a sonography and a hormone profile is a must, because I want to know whether there is a thyroid factor involved, whether there are prolactin levels which are involved. So I want to get an overall idea for her. So usually we do serum FSH, LH, thyroid, prolactin, CBC, and sonography. That's a basic part of our workup when we are doing any patient who walks in with any kind of menstrual abnormality. That is a part of our basic workup. Above and beyond that, we go only when there is usually fertility factor involved. So if a patient is now complaining that my cycles have been fairly regular, but I'm not able to conceive, so then we do something known as a fertility workup, where we do follicular study, where we see whether the patient is actually ovulating or not. If we find that the patient is not ovulating, that is when we do the rest of the workup. So your serum AMH levels, your estrogen progesterone levels, endometrial, like there are a lot of parameters that we have to then assess and then guide the patient accordingly, that now you have to take it the next step. If the patient has completed the family, if the patient is now all right, but her only concern is that her cycles are slightly getting delayed or her flow has reduced, then again, even if all her parameters are normal, we are not in a hurry to label her as a PCOD.
Are there any last additional points you'd like to tell us about PCOD, something which we should look out for, commonest myths that you want us to stay away from?
The biggest myth about PCOD is that because I have PCOD, मेरा वजन बढ़ गया. It is actually the other way around. Because तुम्हारा वजन बढ़ गया है, you now have insulin resistance and now you have PCOD. I've seen cases where they've conceived without a single drug. They've conceived without anything, simply by just losing weight. And these are the patients who were trying for years on end. And just with 6 months of actual strict dieting and weight loss, they've actually managed to conceive.
Fantastic. So thank you so much. This was fantastic. Just to sum it up, PCOD is on the rise and it can be diagnosed primarily with clinical features. I always say this in every talk: clinical features followed by radiology and some hormone therapy if needed. There are different treatment patterns available, whether you have PCOD wanting to conceive, PCOD having completed your family, PCOD wanting to not conceive, and most important before you reach this drug stage is lifestyle modification, and lifestyle modification.